Hi, good afternoon, Dr. Dingowick and Dr. Childress. Today I will be talking about my plan change / EBP project, which is on patient identification compliance. The table of contents are here listed. The first one is change theory, second EBP project question, third identification of problem, four plan of action, best practice and policy and protocol, 5, implementation of the planned action, and 6, the evaluation. The planned change area that I will be discussing today is strict adherence and compliance in identifying patients in the hospital setting to reduce potential errors caused by misidentification. So here we have the review of literature. Google Scholar and PubMed were the two databases used in this research. The keywords that were used were patient identification and compliance, as well as patient misidentification prevalence, just so I can kind of get an idea of, studies that were already being conducted on compliance and, different kind of tools that were used to implement that, as well as the prevalence of, the patient misidentification cases. Data was also collected by reviewing incident reports filed this year in the hospital, as well as in-house surveys asking how often employees comply with the protocol. The designs used in the research articles were mostly quantitative studies measuring the prevalence of misidentification events as well as audits for compliance. The research mainly used simple random sampling in conducting these audits. So now we have the change theory. So the nursing theory that ties closely to my change project is Florence Nightingale's environmental theory. So this theory states that the first requirement in a hospital is that it should not do the sick any harm. And by misidentifying patients, there's a great risk for patient harm. So that being said, I felt Florence Nightingale, her nursing theory is a lot more applicable to my change project than other theorists. So now we have the EBP project PCOT question. So my PCOT question is as follows. On the med-surg floor with 25 nurses, what is the effect of using education techniques and quizzes with nurses compared with not doing these interventions to enforce strict patient identification compliance within 3 months? So my population is the med-surg floor with 25 nurses. My intervention is using education techniques and quizzes with nurses. The comparison is compared with not doing these interventions. The outcome is strict patient identification compliance, and the time frame is within 3 months. So now we have number 3, identification of the problem. Okay, so the posed problem, or the significance of the problem. So the situation that poses a problem is medical staff not strictly adhering to policies and procedures when identifying patients. This problem represents an opportunity for change because it will reduce many preventable medication and procedural errors. A study done by Danaher in 2011 stated that a 2006 study, which analyzed several adverse event databases in the United States, revealed that between 1,300 and 2,700 adverse events related to wrong site, wrong procedure, and wrong patients occurred annually. So here we have statistical data. This is data that was retrieved from the hospital site that I conducted my project in. On July 20th, a nurse from the ER sent a blood bank sample to the lab. She forgot to label it before sending it over. She was informed to bring the patient registration sticker in order to verify she was labeling the right sample. Instead, she showed the technician the actual blood bank armband of the patient. The patient was left with no armband after the collection of the blood bank sample was sent to the lab. The technician asked to cancel and for a recollection. This event depicts how the nurse did not comply with proper policy guidelines for patient identification. And according to Wu et al. In 2022, studies done in the US deduced that laboratory-related work was the most prevalent cause of identification errors. Strict adherence to identification policies should be emphasized in lab-related work due to this prevalence. Now here we have the potential for success for this project as well as the potential for failure for this project. So factors that may lead to success would be healthcare staff acknowledging the need for this strict policy adherence, as well as teaching back the policy and signing a form stating that they received the information pertaining to the policy. Another factor for success would be employees considering the importance of the policy and implementing it in every applicable situation. Factors that may lead to failure include employees believing it is not necessary to follow the identification guidelines because they assume the patient is already who they believe the patient to be. Another factor is an assumed error or issue with the system, such as the barcode scanner, and the nurses or hospital staff believing that there's a true error, making them override the system instead. So here we have more statistical data, which exemplifies what I just stated on the last slide about factors for failure. This one includes a nurse overriding the system due to a presumed system malfunction, which was seen on July 23rd, when an RN scanned the wristband of a patient and claimed it was not working. So then she proceeded to the patient's chart and scanned the barcode there instead. However, the RN used another patient's chart and scanned that barcode instead of the intended patient. As a result, the AccuCheck was uploaded to the wrong patient's medical record. So some research that talks about this is in Al-Ishaq in 2023, which stated that the majority of identification errors occurred from manual patient identification. So number 4, we have the plan of action, best practice, and policy and protocol. The current policy in place by the Joint Commission is at least 2 patient identifiers when providing care, treatment, or services. This is the policy implemented into the hospital. See Appendix C, which states the current policy. According to Sukuple et al. In 2023, this policy aims to ensure a standardized approach in patient identification in order to reduce preventable misidentification errors. So this slide continues the policy and protocols, which is also the same as approaches for the change. So number 1 would be determination of misidentification events using in-house filed incident reports as well as in-house interviews. According to Latham et al. In 2012, determining misidentification events was a beneficial act in the study to decrease patient identification errors. So first, we want to identify what is the prevalence of this issue to begin with. The second one would be teaching will be done to new and existing healthcare staff about the patient identification policy on July 21st, 2023, and repeated annually on that same day. New staff will always be presented with this information at new employee orientation. Now, according to Heemsat et al. In 2015, after education training for patient identification, the adherence of healthcare staff to the process remained above the target goal of 80%, which showed that this was effective. The number 3 would be the department leaders will present the patient identification policy at huddles and use the teach-back method to verify staff understanding. All huddles will be done on July 22nd, 2023, and have a completion due date of August 4th, 2023. The employees will then be required to sign a form stating that they received the proper education. According to Yen and Leisure 2019, the teach-back methods showed to be highly effective in ensuring adequate understanding. So the 4th procedure or intervention would be the education department will create a module and quiz and create a ticket to have the module and quiz sent to all the staff. This module and quiz will open on July 22nd, 2023 and be due on August 5th, 2023. Sheikh et al. 2017 states that quiz-based reinforcement systems shows promise in reinforcing education and engagement. So the 5th intervention would be each unit will add an audit to their QI safety metric dashboard, and 30 audits per month will be required. The numerator will include the number of times the patient is asked, what is your name and what is your date of birth, before any care, treatment, or service, and the denominator will be the number of interactions audited. The audits will begin on July 31st, 2023, and the due date of the audits will be August 31st, 2023. The target rate for the policy compliance will be 100%. Mostafa et al. 2019 conducted an audit for patient identification compliance, which showed the benefits of auditing. However, it did reveal that further attention was needed to enhance the compliance. So here we have possible problems with the approaches. Problems with the first approach include lack of adequate misidentification events due to recall bias or failure to document the incident. Another issue that may arise is a potential for adherence to increase during the study, but to decrease after the study. Problems with the latter approaches include creating a designated time for the education teaching and module creation, as well as not following the protocol, such as the QI audits. So out of the approaches that I listed before, here I have the 3 best approaches. The first one is identifying misidentification errors, because first, in order to conduct a change, the problem has to be identified. The second one would be education training to department leaders. Education is very important for the department leaders in order to pass on the information to the rest of the staff. And then lastly is the teach-back method from staff. So research shows that one of the best ways to ensure understanding is using the teach-back method, and this research was shown here in this project. However, I do believe that all of these approaches together will create an optimal outcome. So in order to operationalize these approaches, first I plan to, with my nurse manager of course, review incident reports and interviews about patient identification errors, then reach out to the education department to conduct these teachings. After the teachings, I will reach out to the department leads to present this information at huddles and ensure a teach-back method was presented. After that, I plan to make sure the modules and quizzes are completed by the due date. And then lastly, I will require the staff to include audits to their QI safety metric dashboard. And once again, of course, all of these being with my nurse manager. As a result of my planned change, I expect for nursing staff to always identify patients before any treatment or service using at least 2 patient identifiers so there can be fewer identification errors. Now we have number 5, which is implementation of the planned action. Plan for implementation. The plan that we implemented in the patient identification compliance focused on the med-surg floor, which contained 25 nurses. First, we reviewed incident reports and interviews for patient misidentification. Second, once we analyzed the prevalence of these events, we reached out to education to provide teachings to department leaders about proper patient identification. Third, the department leaders were instructed to teach the policy at huddles to the staff on their units using the teach-back method to ensure adequate understanding. There was a huddle goal of 60, which began on July 22nd, 2023, and was due by August 4th, 2023. However, only 50 were completed, as seen in Appendix A. Fourth, the education department created a module and a quiz and created a ticket to have them sent to all the staff. To pass the quiz, staff had to score 100%. And fifth, the unit directors were also instructed to create an audit into their QI safety metric dashboard, and each manager had to conduct 30 audits per month. Responsibilities for implementation. Responsibilities for these tasks included ensuring a preferred time for the teachings to ensure staff could attend. It also included ensuring the forms that stated understanding were signed and collected, as well as ensuring the quizzes were completed. We had to conduct audits on the unit and analyze the data to determine the effectiveness of these protocols. We were able to ensure all the protocols were completed. However, the 30 audits per month are still in progress. Number 6, the evaluation. Here we have the outcome. To ensure the change has been implemented successfully, the audit rate of patient identification compliance has to reach its target rate of 100%. It will be measured by random audits on the floor, identifying if the employees are using 2 patient identifiers before any treatment, procedure, or medication administration. I, as well as my preceptor, will be responsible for collecting this data. These audits will include staff names, and so they will receive feedback from the nurse manager based on their performance. So I didn't get to see the study to the end because I ran out of time. I was able to collect 20 audits, and out of those 20 audits, all 20 adhered to the policy, making the compliance rate 100%, which means the target rate was met and the change was effective, as seen in Appendix B. The many approaches, which began with identifying patient misidentification errors and education training, was what facilitated the change, and it was inhibited by a delay in huddle completions, as only 50 out of 60 were completed by the due date. For future use, I would recommend allowing a longer time frame for the department leaders to conduct their huddles to ensure adequate teaching is done for all the staff before conducting the audits. Thank you, Dr. Childress and Dr. Dangowek, for listening to my presentation, and thank you for a great class and a great semester.